We're going to start with the amazing Mariana Garcia, and she'll be talking about, patient selection and, indications, okay? Cool. Mariana, I'll let you take it.
We got a lot of artifact. All right, so let's keep moving. This is our talk on patient selection. I did use AI. All my fellows are using AI now, so I'm going to get into this group of using AI for my talk. And first of all, let's talk about the chest pain guidelines. The latest one are the 2021. And the big sort of paradigm shift was that coronary CTA was changed to first line, right? So anyone with intermediate risk stable chest pain or selected low intermediate sort of acute chest pains, and we'll talk about that. And patients without known CAD have a class 1 indication for a coronary CTA, right? And so this really marked a fundamental shift toward earlier anatomical evaluation over relying solely on stress tests. Alternatives to coronary CTA, if for whatever reason we can't do that, the sky's the limit, and you know it. Nuclear SPECT, nuclear PET, exercise treadmill, obviously left heart cath, and stress MRI. And so these are the guidelines here. As you can see, CCTA preferable in those less than 65 years. That's based on sort of your pre-test probability of coronary artery disease. It's not like a hard number. The VA, I'm scanning 70, 80-year-olds all the time, and not an optimal preventive therapies. And things that also favor the use of CCTA, if a prior functional study is inconclusive, we get these sort of like 5% reversible SPECT, which could be artifactual, sure, get a coronary CTA. And then obviously if you have high quality imaging and expert radiologists or cardiac imagers that can do these, go for it. And then also if there is concern for anomalous coronary, CTA is your first line. And this is sort of the same idea, the same diagnostic fork and routing the patient. You do want to sort of favor that functional testing in older patients, higher likelihood of complex disease. We get patients who have extensive, bypasses or stents. I favor sort of more the functional testing in those. If I want to assess the ischemic burden, then I favor functional testing. Or if I know that they have obstructive coronary disease from other prior testing. And this is sort of a cardiac CT toolkit. Our first line, and we do these all the time, are non-contrast calcium scoring. This is more for the target asymptomatic, and this is more for initiation of statin therapy, right? It's sort of guiding us towards that preventive therapies. Obviously, for coronary CTA, we know it's for suspected coronary disease. It gives us amazing high-resolution anatomy, stenosis severity, and plaque characterization. And there is this, sort of group of people that are always talking about this triple rule-out CT in the emergency room. If you have someone in the emergency room with chest pain, you can consider this like triple rule-out CT, where you rule out aortic dissection, pulmonary embolism, and coronary disease. But obviously, it is a lot of a process that you need to set up with your radiology team and your techs and the emergency room, and making sure it's like the adequate test for these patients in the emergency room. All right, this is sort of the same idea, and just always remember that the negative predictive value of a coronary CCTA is incredible, so that's why it's more that your low and intermediate risk patients that you want to consider for a CCTA. More than that, and you will be talking, today is a big coronary day and a big CAD-RADS day, and they will be going through this, but obviously coronary CTA has the amazing ability to sort of give you that biology and sort of assessment of your high-risk plaque, and you will go through these characteristics like positive remodeling, low attenuation, napkin ring sign, and then the spotty calcifications, and we will get examples and cases of this high-risk plaque features, which is pretty awesome. Lastly, as you guys know, the structural world is ever expanding. Here at Emory, they come up with the craziest stuff, and they need sort of structural pre-planning all the time, right? So we're getting CTs pre-TAVR, pre-TMVR, pre-TTVR, pre-Watchman, recoiling PDAs. All of these patients require a coronary CTA for procedure planning. Obviously, in the electrophysiology world, it's also a big indication for pulmonary vein mapping and left atrial appendage thrombus rule out. And obviously, you're basically getting the patient out of an invasive transesophageal echocardiogram. So amazing tool for electrophysiologists, and more also being used for VT ablations. And then, like I said, coronary CTA, at least at Grady and VA, we have a really cool setup for cryptogenic stroke and left atrial and left atrial, left ventricular thrombus rule-out. Again, it also offers this very comprehensive evaluation of embolic sources of cryptogenic stroke. And again, not needing to have an invasive transesophageal echo as the tool for this assessment. Coronary anomalies, like I said earlier, it's sort of the premier gold standard modality for precise 3D anatomy. It really identifies high-risk features like intramural course, interarterial courses. You can and you can especially consider this in patients who are young athletes or have sudden cardiac death or syncope. And in heart failure, more and more being used as your ischemic evaluation for etiology of heart failure. Obviously, if you're looking at other cardiomyopathies like ARVD or HOCM, it's more MRI that would be your first choice. So again, let's balance it out. The limitation of CTs, yes, obviously with photon counting, and there will be a talk on this, blooming artifact will be less of a issue, but it is one now with even our big dual source scanning scanners. And then obviously cardiac CT is susceptible to motion artifact, so we will be talking about, how to appropriately prep the patient for good cardiac control, reliance on iodinated contrast, and of course radiation exposure. But honestly, the strengths are amazing, the capabilities are great, and ever-expanding indications for it, so pretty amazing tool. And we will be talking about sort of that future bridge and anatomy, from anatomy to physiology, and we will be touching on CT-FFR and this sort of computational analysis in order to understand and determine lesion-specific ischemia. So in conclusion, it's sort of this complete biodigital twin of a patient's heart. You can get detailed anatomy. You can work on preventive cardiology, and with your calcium scores, you have incredible pre-procedural planning and this sort of surgical architect. And lastly, our AI tools for plaque composition and physiologic assessment. And with that, I thank you.